Hey, I'm Joel Beachy, first-year cardiology fellow at Mayo Clinic in Rochester, Minnesota. I'm here with FITsOnTheGO at the ACC Legislative Conference, and I'm honored to be accompanied here by Dr. Robert Shor, who's the chair of the membership committee for the ACC. Welcome.
Thank you very much. It's an honor to be here.
All right. So just wanted to talk with you a little bit about the prior authorization process. I was just in on the first session here that you and Dr. Andrew Wexler delivered on the prior authorization process, and it's very interesting. Thank you for that. So to start off with, the prior authorization process, I know, is the bane of many physicians' existence. It's something that we as fellows maybe don't have a lot of exposure to, and we haven't been involved in that process as much at this stage in our training. But can you take us through a little bit about how the prior authorization process affects a daily clinician's practice?
Great. Thank you very much for the question. I have found that the prior authorization process is, as you said, a real bane of existence. The prior authorization process is basically that when you make in your best medical decision the request for a particular test, particular medication, particular treatment has to often be approved by some other third party. The insurance companies use what are called RBMs, or Radiology Benefit Management Groups, to help determine by their own particular, often opaque criteria whether they're going to approve something. And we sent a survey out to members in 2016 trying to quantify what percentage of clinicians found that this was actually a problem, and close to 3/4. The amount varied from 0 to around 3 per week that people had to deal with, and usually a large percentage were anywhere from 30 to 60 minutes that it required. This was felt to be burdensome, delay of care, frustrating, hassle factor, costly to the practice because of the requirement to have additional FTEs or employees have to go through the process, and frustrating for physicians because it would take them away, and providers take them away from direct patient care to sit on a phone for 30 to 60 minutes. So we then created a work group, and the process that we came up with, the three main features were: one, to have the American College of Cardiology's robust AUC be accepted as the tools to determine prior authorization. Number two, we have found from other studies, use of the focus tool and other reviews, that probably 8 to 10% fall out of appropriate use. Not that they're inappropriate, but that the guidelines or the appropriate use criteria are too narrow in focus and don't account for certain clinical scenarios. And so the second issue was to streamline the process for those that fall out of routine AUC. And the third, which we have found an incredibly frustrating experience, is the requirement by these RBMs to do test substitutions. For example, something that makes little sense to me, but you have a patient who, for a variety of reasons, would best be served with a stress echo. They will deny the stress echo and approve a surface echo and a treadmill. The combination of the two is more expensive than if you'd done the stress echo in the first place. There was one state years ago that they were trying to mandate all MPIs become stress echoes, and that's inappropriate also based on patient habitus and a variety of other issues, left bundle branch block, whatever. So the decision is really felt to be best rest with the clinician in making that decision. So test substitution is also felt to be something that is not in the patient's best interest. As a result, we've created collaboratives with other organizations. We have tried to change the rules on a state-by-state level, have been variously successful. We continue to work. And the last thing is that we're working on the PAR tool. And the PAR tool is the tool which enables us to collate the data on prior authorization denials, things that require peer-to-peer reviews, and anytime the study has been denied, substituted, absolute denial, anytime it requires another call. And that is to be the canary in the mine, so that we can hold accountable the RBMs in the decision-making process, that we can then go and say that they are meeting the appropriate use criteria by the college. which are widely accepted and now accepted by CMS as one vendor, and be able to then use that information on behalf of our patients to improve care and access and cost.
So we hear a lot about the appropriate use criteria, and I know that the ACC has a set of appropriate use criteria. Is that what is being used by the RBMs currently with these prior authorizations, or what criteria are they using? Do we know?
That's a great question, and the answer is some are using some form of AUC. There are other RBMs where it's opaque, and they are not sharing their proprietary prior authorization guidelines. And so they may or may not be similar in any way to the college's AUC. Sometimes they'll take an AUC and misapply it to a different procedure or different test, and that creates conflict as well.
So you discussed the PAR tool during your session this morning, and just were briefly discussing that with us now, but can you briefly tell us a little bit about this tool and how you feel that this is going to impact the future of prior authorization?
Thank you again for the question. Great question. The PAR tool is our attempt to document where the prior authorization process fails. And our attempt is to document where the cases meet the appropriate use criteria from the college and yet are not approved, creating delays in care and potentially impact the quality of care as well as the cost. The forms themselves are online at www.acc.org/partool and take about 2 to 5 minutes to fill out. And we are hoping that in November, particularly the first week, that all prior authorizations that are denied will be, people will enter the data, so we will have robust data. We did a soft launch earlier in the year, and we're going to do the hard launch in the beginning of November. But as you all finish your training, this is a reality that you're going to face all the time and be very, very frustrated with, I'm sure, because it's frustrating to the rest of us. And the sooner we can get the information, the sooner we can get the support and change our current reality on behalf of our patients, will serve our patients well and the providers in the future.
Well, thank you very much, Dr. Shor. It's been great talking with you today.
Thank you very much. I really appreciate the opportunity to be here with you. And again, if there are any questions, I'm always happy to answer them. Thank you.
All right. For more videos like this, you can visit youtube.com/FITsOnTheGo.